along 3 cycles and see whether there's a change in the temperature. Because what happens in the middle of the cycle is the temperature goes up as your progesterone levels rise. So that can be done. You can use an ovulation predictor kit. That is fraught with difficulties with polycystic ovary syndrome because it depends on the levels of luteinizing hormone. And if they're high, as they are in polycystic ovary syndrome, you may get a false positive result. And of course, time progesterone measurement is another way of doing it. So that's just really to see whether you need treatment at all. And if you do, what's the first line of treatment? Well, as I say, if you're overweight or obese, then that itself can have an impact on ovulation. So a good strategy would be to try and reduce weight and reduce insulin levels. Can you do it? Yes, you can. And it's quite interesting that if we look at this scale here, that's a logarithmic scale. So that's weight in kilograms. So this is a group of them, and during this diet study, they went down to 85 kilograms. So nowhere near the normal range, but a significant reduction, modest reduction of 5 to 10%. And you see what happens to the fasting insulin levels, which are high, and they go right down on this diet. And if you give a glucose challenge and you measure the sum of the insulin levels after the glucose challenge, you can also show that's reduced. So there's a big change in metabolic indices. Your blood sugar also gets better. But very strikingly, and that's been shown by a number of studies now over the last 20 years, that diet and lifestyle changes improve ovulation rate and fertility on their own. And so you may not even need to have fertility treatment other than the diet. So that's an important thing. Diet and lifestyle changes will improve the frequency of ovulation if you're overweight or obese. Note a caution here, because if your weight is normal, and particularly if you tend to be at the lower end of the normal range, then diet is not going to be helpful. So you have to be careful that you don't get underweight as a result of dieting too rigorously. So what are we trying to do? Let's say we've got a woman who's managed to lose a bit of weight, but she's still having problems with irregular cycles, not ovulating regularly, or somebody who's of normal weight and not ovulating. Well, then we want to try and induce ovulation, and that's to try and get a single follicle, because normally you only release 1 egg in a menstrual cycle, and that's distinct from the treatment that you might undergo if you were having in vitro fertilization, where here the aim is to try and stimulate as many follicles as possible to collect as many eggs as possible. That's logical, but you don't want that if you're simply trying to restore normal ovulation. In fact, you really don't want it, as I'll show you in a minute. So how can we do that? Well, as I say, the important thing is to try and increase the levels of follicle stimulating hormone, which are a little bit suppressed. Just get them up into the normal range. And this shows the feedback axis, how the ovaries work. So here's the pituitary gland. This is not to scale, by the way. The pituitary gland is about the size of a pea, very simple piece of the brain. The pituitary gland produces these three hormones: luteinizing hormone, which tends to be a bit higher than normal in polycystic ovary syndrome, and follicle-stimulating hormone, which, as I say, tends to be a bit lower than normal in women with polycystic ovary syndrome. Now, normally what happens is when the ovaries stimulate, and estrogen is able to restrict the amount of hormones that are made by the pituitary gland. So it's a feedback system, a sort of servo system, which helps to keep things in balance. So if you're making too much estrogen, the estrogen signals back this negative feedback mechanism and tells you to switch down the FSH. Equally, if you're not making enough estrogen, then the pituitary gland senses that and produces more FSH. So one of the strategies to stimulate ovulation, to increase FSH, is to use what's called an anti-estrogen. So what that does is to block the effect of estrogen on the pituitary gland. The pituitary gland thinks, oh, not enough estrogen around, and puts out more FSH. So that's a clever way of doing it. And I'll talk a little bit about another way of doing that. There are so-called aromatase inhibitors, and that prevents the conversion of testosterone to estrogen. And then that does the same thing. It just lowers the level of, temporarily, lowers the level of estrogen. And so the same mechanism is invoked here. And you make more FSH. So both anti-estrogens and aromatase inhibitors, such as letrozole, will stimulate FSH. And that's can simply be done by oral treatment. And we'll come on to that in a bit more detail. So this is what you want. Here's an obviously polycystic ovary. You see the increased number of follicles around the edge here. You want a single follicle to develop as a result of treatment. You do not want this. That's called hyperstimulation syndrome. And that's a very, very big ovary with lots of big cysts and a lot of fluid in the belly. And that's not good news. Fortunately, that happens pretty rarely, and particularly rarely on clomid treatment, but it can happen. And it's a danger. And that's one of the reasons why, if you're going to have treatment to stimulate ovulation, it needs to be done in centres where they are actually able to monitor the treatment. Okay, so what about metformin? Because there have been swings and roundabouts about metformin. Will metformin help? It might. And we're talking specifically about fertility here. Because there are a number of studies now which show that your cycles may be a bit more regular, and ovulation might be a bit more frequent with metformin. In some women, it works beautifully, particularly if you're a little bit overweight. So you take metformin and you have more regular cycles. And if you're trying to conceive, that's fine. But that's fine if you're not in a hurry to conceive, because it doesn't work very well in quite a high proportion of women. So many women will have more regular cycles. In those, it won't be regular enough. They won't be ovulating often enough to give them a good chance of pregnancy. In others, it won't work at all. So it comes back to the issue that was raised earlier. If you're on metformin and your cycles haven't improved, certainly after 6 months, then don't stop there. Just say, it's not working. It will in some women, and it's very good if it does. But it isn't a panacea. It's not much use for treatments unwanted here. It's not the ideal treatment to regulate your cycle if you're not trying to get pregnant. You'd be better off having oral contraceptive to do that. But it does have a place, particularly if you want to slightly increase your chance of ovulation and you're not in a desperate hurry to conceive. So the first line of treatment is still clomiphene, citrate, or clomid. It's a simple regimen, 5-day course of tablets. It does have some side effects, notably hot flushes and headaches. Those tend to be temporary during the time that you're taking the tablets or for a short while afterwards. It does have a good rate of ovulation, and if you follow the rate of pregnancy over a few months, the conception rate is similar to that in women who are trying to conceive naturally. There's still a multiple pregnancy rate of around 10%, and that compares with about 2% or less in the general population. So it would be, certainly in our centre, we always monitor the first cycle of treatment. Not everybody does that, but it isn't something that ideally should be started off in general practice, although it can be later monitored once the cycles are well established. So there's this new group of compounds called called aromatase inhibitors, which, as I say, prevent the conversion of testosterone to estrogen, because that's how you make estrogen. You've got to make testosterone first. So those of you who think that testosterone production by the ovary is abnormal, it's not. It's just that women with polycystic ovaries tend to grow, so that can have an effect. But it's a very important pre-hormone, if you like. You've got to have testosterone to make estrogen. And what letrozole does is it temporarily, during the time that you're taking it, again, you take it for a short while, interferes with that production of estrogen. So your estrogen levels drop, up go your FSH levels because of that lack of negative feedback. And this very recent study from Richard LeGros and his colleagues, this was a beautiful study, which actually you'll see another one of the studies, which was looking at the combination of metformin and clomiphene. But this was a very carefully performed multi-center study where they did in a double-blind fashion, so none of the doctors and none of the women knew whether they were getting letrozole or clomiphene. So what they found was that there's actually a higher live birth rate compared with clomiphene. So that was encouraging. Fewer side effects, actually there were different side effects. So you tended to get different effects with clonidine, sometimes feeling faint. It wasn't usually enough to stop people taking the tablets. And there's still a question mark about whether it's safe, because what's held up the studies with aromatase inhibitors is an initial study published only as an abstract in which there seemed to be a higher proportion of fetal abnormalities in the babies that resulted. And that meant that the drug manufacturers actually said, oh no, we're not going to allow this for treatment of fertility. Because it was mainly introduced really for management of breast cancer, to drop estrogen levels in women with estrogen-sensitive breast cancer. But it needed this sort of study. And so this is a very thorough study, and they're going to follow the offspring. So far, so good. It doesn't look as if there are any higher incidents of fetal abnormalities, but they need to know, do much more follow-up. But it's looking very promising. So you may find this drug creeping into the schedules over the next year or two. If that doesn't work, then we can give follicle-stimulating hormone directly. And this works very beautifully, but it's much more difficult to monitor because it's easy to overstimulate the ovary with follicle-stimulating hormone because you're overriding the normal feedback mechanisms. So this was a regimen we developed some years ago, where we started off with a very low dose of, I think we now use a much lower, even lower dose of this, 37.5 units or something like that. And then keep that going for quite a while, up to 14 days in the first cycle, monitoring the changes by ultrasound. So watching for that follicle to take off and look as if it's going on a path to ovulate. If it doesn't happen after 14 days, we can very slightly increase the dose, because what we're trying to do is to find that threshold level of follicle-stimulating hormone that allows a single follicle to grow, and not to push it up too high so we get multiple follicles as you would for IVF. And that's the regimen we use.
Sorry.
Probably do without the new software.
Sorry, that's probably my computer.
Okay. So this was a series which was written up by a medical student who was doing a bachelor's degree with us a few years ago, and that was the first nearly 200 women with polycystic ovary syndrome. And you'll see that we tended to not treat, in the first instance, women whose BMI was greater than 30, but there were some who were overweight. Chronic anovulation, so they weren't ovulating very often or at all. So these were women who were having either no periods or infrequent periods. And by definition, they hadn't responded very well to clonidine. And so we had, of these 199 women, we had something like 900 cycles, and you'll see that the percentage of cycles in which ovulation occurred was not too bad, 72%. And remember, these were women who had not responded very well to clonidine. And the most encouraging thing was that in the great majority of these cycles, there was just a single follicle that ovulated, and about 50% pregnancy rate. Not too bad, could be better. Miscarriage rate actually, since we were picking up very early miscarriages, no greater than in the general population. And this was important, really, for us, that you could keep the multiple pregnancy rate down. It may seem very attractive to have twins in one go, or even triplets. It's not. You can imagine the problem with triplets, but even with twins, you have a much higher rate of problems that babies come up. So you want to try and avoid that. And that horrible thing we saw with the ovaries being overstimulated and lots of follicles, a very mild form of that occurred only in a small percentage of cycles. So we were successful by doing this low-dose regimen in our goal of getting single follicle ovulation. And now most centres actually using this method. Don't forget the importance of calorie restriction. That's terribly, terribly important. And ideally, that should be given before, well, should always be offered before, in women who are overweight or obese, before starting treatment to stimulate ovulation. Now, just before I come on to metformin, just to mention something raised before, which is and Camilla was talking about it, laparoscopic ovarian diathermy, that's drilling holes in the surface of the ovary, which sound pretty brutal. I can tell you, compared with what the gynecologists used to do in the old days, which was the ovarian wedge resection, you took out a big wedge of ovarian tissue. It's gentle treatment, but even so, it is invasive, and you wouldn't want to do it unless there was a good reason. Although it's tempting when you have a laparoscopy, oh, let's just give them a drill. It's not a terribly good idea because it can cause complications. You may get scar tissue forming, which then affects the quality of the tubes or affects ovulation. So ideally, you wouldn't do it. But in women who haven't responded to clomiphene, it is a useful alternative because it does seem to be useful it's a one-off procedure. And for some women, attending regularly for monitoring for this low-dose FSH treatment is not easy. And nor are there that many centres that can offer it, unfortunately. Fewer as time goes on. So laparoscopic diathermy is a viable alternative. And in about 50% of cases, in women who are not responsive to clomiphene, you wouldn't do it before clomiphene, but after that, in about 50% of cases, you do get a resumption of ovulation with a reasonable pregnancy rate. Although quite a few of those women will then need to go on and have clomiphene treatment. So it doesn't always work on its own. It is, however, a good treatment option. And just coming back to metformin now. So this is the idea that if the high insulin levels are playing a part in the causing problems of ovulation, then lowering insulin levels is quite a good way of doing it. Metformin will do that. But let's have a look at what the literature tells us, the medical literature. As I mentioned, there's a significant but modest increase in ovulation rate. This is from properly conducted clinical trials. But the effect on body hair is not great. For some women, it actually does seem to work, but for most people, it's not the ideal treatment if you've got skin problems. And in the study that Adam Bailyn and colleagues did, this was a multi-center study, they couldn't be sure that the improvement in ovulation rate was independent of weight loss, because, as you know, that metformin can be associated with gastrointestinal side effects, so you eat less as a result of that, and therefore you lose weight as a result of that. But so they couldn't be sure that the effect of metformin was independent of weight loss, but it worked to the extent that it improved ovulation rate. But the proviso is it improves the rate of ovulation, but it doesn't regularly give you ovulatory cycles in the same way that successive courses of clomiphene would. And therefore, if you are been trying for a long time to conceive, then that's why clomiphene and maybe now letrozole are first-line treatment rather than metformin when it comes to fertility. But if you're in this interim period where you want to just see whether you can improve your frequency of ovulation and you're not in a desperate hurry to conceive, then I think there is a clear cause. There's been a lot of, over the last 10 years or so, a lot of work about combining metformin with clomiphene to see if you can improve the ovulation and pregnancy rate. And really the data weren't terribly clear until we had a couple of very large studies, and this was another Rick LaGros study published in 2007. And here he's recruited over 600 in this multi-center study in North America. And you can see the three treatment groups. So there's metformin alone, so okay, you can see that, so that nobody in the three groups knew what they were getting. Metformin and placebo, clomiphene and placebo, so clomiphene alone, and a combination of the two. And really the bottom line is the live birth rate, because that's what we're really interested in. Am I going to have a live baby as a result of this treatment? Well, if you just have metformin, that's a very important figure, okay? 7%. So that's why metformin is not itself the primary treatment for fertility. It may help, but it's certainly not as good as clomiphene, because clomiphene alone will give you a 22% live birth rate. Clomiphene with metformin looks slightly higher, but it's not significantly high. So you're not really, by adding metformin to clomiphene, not really affecting the live birth rate. So there's probably not much point if you're having clomiphene having metformin as well. Doing it successively, having metformin, seeing whether it improves cycle, then going if you're not in a hurry, is not a bad strategy. So finally, let me just come back to this issue of the global concept of the impact of polycystic ovary syndrome on fertility. And so I'm very lucky to have been working for some years with a group in Finland, where we have this cohort of women and men, but obviously we're interested in the women here. Something over 4,000 women, all born in the same year, 1966, and they've been followed up repeatedly since then. And there was a big study of reproductive history at the age of 31. So at the age of 31, it was found that about 24% had symptoms of polycystic ovary syndrome. So we're able to pick out from this birth cohort, all born the same year, a cohort of women who have symptoms of polycystic ovary syndrome. We can't be sure of the exact definition, but we can be pretty sure that most of those women will have polycystic ovary syndrome. So not surprisingly, women with symptoms of polycystic ovary syndrome suffered more frequently from infertility than those who didn't. And it took them a longer time to get pregnant. So fecundability means time to first pregnancy. Again, not very surprising, given the frequency of ovulation reduced. But what was fascinating about this study, in women at the age of 31, the overall pregnancy rate was similar in both the PCOS group and the controls. They received 3/4 of women in both groups conceived. The miscarriage rate was similar. That's very, very important. It comes back to what I said earlier. Polycystic ovary syndrome doesn't increase your risk of miscarriage. And in this initial study, the number of pregnancies and family size was similar. I'll come back to that in a moment. But there's clearly an impact of being overweight. So the infertility rate was much higher in the obese PCOS group than the obese controls. So if you were overweight and had polycystic ovaries, compared with women who were overweight without polycystic ovaries, you see you have a double rate of infertility. So that shows you the interaction between being overweight and having polycystic ovaries, and the impact on fertility, and why it's so important to at least try diet and exercise before you try to conceive. But then, very recently, we were able to look at the reproductive history of these women at the age of 45. There's a similar figure to what we saw before. So 6% of women with polycystic ovary syndrome had treatment for infertility, compared with 2.4% of who didn't. And this, again, is very encouraging. Women with polycystic ovary syndrome had at least one child as often as the reference population. Very good news. They had slightly smaller family size, and that's important at a population level, but you see that the average is still 2 children per family compared with 2.5 in the reference population. That's, as I say, significant at the population level, important, but on an individual level, it meant there was still a very high proportion of women who managed to have more than one child. But again, here's the impact of obesity. Women with polycystic ovary syndrome have fewer children than obese women with no symptoms. Once again, the interaction between having polycystic ovary syndrome and being overweight is there to see. So, in summary, infertility is due to infrequent or absent ovulation. Overweight or obesity complicates that. It can be treated successfully in most cases. We don't conceive spontaneously, and many do actually, even with infrequent cycles. Diet, perhaps metformin in the first instance, clomifene, letrozole, FSH. Diet and lifestyle changes improve fertility in overweight women with polycystic ovary syndrome. And that's really very good news, because one of the problems, of course, about dieting is it's very difficult to sustain. We know that even if you've managed to diet and lose weight for a few months or a couple of years, even if you go back to your normal weight, you're reducing your risk of diabetes. So it does make a difference. And particularly in regard to fertility, we know that if you can lose 5 to 10% of your initial weight for a few months, you're going to greatly improve your fertility. So that works. But it's not metformin, not the first choice for fertility treatment. It's not guaranteed to work, but it may improve the frequency of ovulation slightly. And very importantly, Most women with polycystic ovary syndrome have normal or perhaps slightly smaller family size. Thank you.
I can ask one of the trustees to come and grab the microphone. If you have a question, please raise your hand and we will get to you. We normally have many questions for Steve, so please be patient, just keep your hand or just raise it, and I will point, I'll try and get to people in order of when they put their
I'm
hand
not escaping, I'm just going to get tricky.
Great.
Thank you. I've been trying for a baby for about just over 6 years. Been to the doctors, seen various 3 or 4 different doctors at the same practice, and initially, well, mainly 9% of the time I was told the one and only reason you're not pregnant is because you're overweight. As soon as you lose weight, you become pregnant. It was only earlier this year that I was finally diagnosed as having cystic ovaries when we did another internal examination. All my levels for everything seemed to be okay, but I did some of the symptoms or what have you. And they said, we're looking at everything all together and then looking at internal examination, do you have it? So the lady said that she was a consultative specialist that said to me, potentially I'm continue on Clomid. So I've been on that, but to be honest, obviously the stresses of trying for family and what have you, I've just said to me, let's do it, but no, we can't be doing this anymore, the stress. So I've only taken it occasionally over the last so many months. I did mention about Clomid, or the doctor mentioned about Clomid, but then she said, oh, it's not really going to be worth it for you. You've got to lose a dramatic amount of weight, lose about 10 stone, and then come back to me after a year if it's not worked. It will be a year in March, and obviously with the stress, everything I've put on the freeze to I've lost and what have you. Is there anything, basically, so after all of that, is there anything that you could perhaps recommend for me to do? Or, because obviously I appreciate my BMI's got to be 29 or under for the NHS, and obviously it's never going to be that, because another doctor sort of, sort of laughed and said, you can't use 10 stone, I do not recommend you doing that, it would be unhealthy for you to do that. So I'm waffling now, but basically, yeah, is there anything you just
No, it's important, it's a familiar story.
Yeah.
And of course, it's important to try and lose weight. But if you do lose weight and your cycle's still not regular, or if you're having real trouble losing weight, then it's perfectly reasonable to have clomid. It works less well if you're overweight. There's some evidence, although there haven't really been very good studies on this, that if you lose weight, you're more likely to be responsive to clomid. But the problem, as you say, is that if you get stuck for one reason or another, you can't lose weight, you tend to be dismissed. And that's not right. I mean, it's important and when it comes to clomid treatment, there's no reason why you shouldn't have clomid. Ideally, it would be in a centre where they're used to monitoring cycles and are able to move on to other treatments if it doesn't work. But just because you get stuck with your weight, it shouldn't prevent you having fertility. I mean, there are, of course, additional risks with pregnancy, and ideally you want to lose weight, but sometimes you just do get stuck. And you get into this vicious circle where you get fed up and depressed and you eat more. That doesn't help. So ideally every regional centre every GP practice would have a diet and lifestyle clinic which includes psychotherapy and previous practice you've got. It would be great if that was all prepared. And many general practices actually do have something like that. So if you're struggling with that, you can see that that doesn't work. You may have access to counselling and psychotherapy to help you. But not everyone has that. And certainly not even the major centres have it. So you can't just say, or you shouldn't just say, sorry, we can't help you. It may be that when you have chronic feed, it doesn't work. And then it's another incentive to try and lose a bit more weight. But don't give up, because that seems to be the theme of the day. Don't give up. Keep persistent.
Next question. Chris, in the back.
I conceived my daughter after having a ovarian drilling, and I'm just wondering if in the future we did want to have another child, what's the likelihood that I would have to go down the ovarian drilling route again?
Right, so ideally you wouldn't want to repeat it, although you can. I think it depends on what's happened to your cycle. Most women, ovarian drilling gives a succession of regular cycles for perhaps a year or two. In others, the women carry on having regular cycles, in which case your chances of conception are still quite good without any further treatment.
I was for 6 months,
Yeah.
and now it's started to really grow.
That will be fairly typical. And, so I think you'd start again and you'd say, right, start with Comet, see how that works out. If that doesn't think about having further ovarian drilling, it can be done. It's certainly much less traumatic and invasive than the old-fashioned wedge resection. But it's not ideal because it can cause scar tissue.
Am I right in thinking, because I had the ovarian drilling after an nephrectomy, that I'll ovulate every other month because I've only got the one?
No, you're ovulating every month, but from the same
Same
ovary.
ovary. Okay, thank you.
You should.
Next question in the middle.
I was wondering if there's a difference in kind of ability to conceive within the normal range, weight range, with a BMI of say 21 compared to 24. Is there a benefit with getting it as low as possible? And also, what's the recommended level of exercise to manage this?
Okay. So, important things as far as insulin levels is concerned. If you've got polycystic syndrome and you're normal weight, you are maybe relatively insulin resistant, but it's insignificant because your insulin levels are likely to be pretty well in the normal range. It's only when you're overweight that then that becomes more of a problem. And so it follows that if your weight is in the normal range, that it won't help to lose weight in terms of your insulin sensitivity. And that, although we don't have a lot of data, the danger is, as I mentioned earlier, if your weight's in the normal range, say your BMI is 24, you diet and exercise, and it goes down to 18. Or more likely, if you're at the lower end and you diet and exercise, there is no switch off for different reasons. If you're undernourished, basically. Does it make a difference if you go from BMI 24 to 21 in terms of ovulation rate? Probably. So it's not worth it. So if your BMI is in the normal range, you can be pretty sure that dietary habits are correct.
Question at the back.
So what I'm looking at, are there any combinations of foods that tend to work better for the lower weight range?
Combination
Of treatments?
Well, as it happens, clomifene works better if your weight is in the normal range. That's really the most important thing. It doesn't seem to make a difference where you are in the normal range. Although if you're thinner, you tend to be more sensitive. You have to watch out that you don't overdose. And sometimes when you're very lean, we will, as I said, they're still in the range, but they're at the lean end. We will start with a lower dose of clomifene because they tend to be more sensitive to stimulation. But the principle of treatment is without
What about metformin in terms of regular release versus extended release?
Well, okay. I think there haven't really been any head-to-head comparisons with polycystic ovary syndrome. It seems a really sensitive thing to do. Usually only got to take a couple of months a day. So if you're on it and it's helpful, that's a reasonable alternative.
Next question at this table.
I'm the mom, so I'm not going to go into great detail over things, but I just want to know something. If somebody has had the misfortune to lose an ovary, and they're very, very low and then about it, worried about the same thing happening to the other ovary. So it's been mentioned that they could freeze the eggs. But because of the problems with overstimulation and things, would you recommend that happen? Because there's no partner on the scene yet. If You know what I mean?
Okay, well, egg freezing is a whole different area. But as far as if you've lost an ovary, unfortunately, I've lose an ovary because of surgery for another reason, it's very unlikely that the other ovary. So if it's there are local surgical reasons for that, then there's no reason what to expect that the other ovary is going to.
It was a cyst, and not a dermal cyst, the other kind of like follicle, I think.
Okay, right.
That
Okay,
and
so
it twisted and.
okay, yeah. So it's very unlikely that the other ovary undergo the same thing. So and you can function perfectly well on one ovary. As I just mentioned, you could. If in women with regular cycles, you have one ovary, it's the same ovary that ovulates every month. There's no cost.
So at this stage, really, it might be better just to sort of leave it.
Depends on age.
You don't want to do anything to harm the other ovary and then lose.
No. And a general principle about fertility is that you're in your most fertile in your early 20s. Once you get to your mid 30s, mid to late 30s, the fertility rate drops off. Only you're infertile, but you have a low fertility rate. So the prospect of egg freezing will come in for various reasons, but it's particularly in young women who think they're not going to they want to get pregnant until they're in their 30s and they have a literary career. And I think actually that says something more about our society. We won't get to that. But they want to do that, and therefore egg freezing is not increasingly an option because the technology is much better. But it's still not the best option. The best option is to get pregnant naturally if you can, and as long as you're still in your 20s and early 30s, there shouldn't be any pressure.
There's a question behind you, Chris, but just before we go on, Steve, can you clarify about losing an ovary and any potential link to PCOS, just so we can, losing an ovary.
Losing an ovary because of a torsion that they're sort of twisted.
Is it linked to PCOS or not? I just want to clarify so everyone doesn't go out.
It's what you said earlier, Rachel. Having isolated cysts in the ovary, big cysts, or having ovarian pain for any reason, is not a feature of polycystic ovary syndrome. It doesn't mean you can't get it if you've got polycystic ovary. It's no more likely to happen in women with polycystic ovary syndrome.
Just want to be sure everyone's clear. Yeah, next question.
So, I don't know how to ask this question in a way, and I wonder how many people in the room affects as well, but we haven't really talked too much about stress and depression. And I wonder if there's been any studies or anything about the impact that has on fertility. Is it a chicken and egg situation? Because in my case in particular, my period stopped after my dad died, and I felt that a lot of that instantly was because I was more stressed than I've ever been in my life. So I don't know. I mean, obviously, I still have polycystic ovaries as I work through that, but I don't know.
That's a very good question. There are two issues here. If you've got, there have been surveys which Rachel is very aware of, surveys of women with polycystic ovary syndrome, and there is a higher prevalence of depression, and it's probably because, and it seems to relate to the severity of symptoms. That's one issue. The other issue is if you have a very specific reason to be stressed, depressed, for example, that can affect your chance of ovulation quite independently of whether you've got polycystic ovary. It's a very well known mechanism. So that stress, whether it's metabolic stress because you're very underweight, whether it's emotional stress, whether it's due to exercise, switches off your periods, but it's a different mechanism. What happens is that the levels of luteinizing hormone follicle stimulation drop, and therefore the ovary is not getting the right stimulation. So dealing with that stress, getting over that, usually, whether you need help or not, then usually leads to resumption of cycle. So it's not due to your polycystic ovaries, but the women who've got polycystic ovaries are not immune from that type of problem.
Yeah, question next.
One of your slides had a list of 4 drugs of the
Oh, yes, yes, okay.
sensitising drugs.
Yeah, they were, I shouldn't,
Would you be able to use it more information on those?
I can. Okay, thiazolidine diamonds. They've been used for treatment of diabetes. They do lower your blood sugar. They lower your insulin levels. They cause your fat levels to go up, and they cause heart disease. So they're not. That's why I should have struck it through. Deep thyroinositol is a sort of it's a modification of your body sugar, and that has been shown in experimental animals and in some people to lower insulin levels. But it really, they started a clinical trial. It's a multi-center trial by a drug company in the back because it didn't work, basically. There are newer derivatives which are similar, and they haven't yet been clinical trial. That's why these are things which have been suggested as insulin lowering drugs, but they haven't really met the criteria you need to use in clinical use. So not. By the way, the only way to find out that the drug company, the ban of the drug company trial is to look in the Wall Street Journal, because their shares have gone down. It wasn't reported in medical literature, and that is a real problem. Negative studies on it. Diazoxide you wouldn't use because it lowers blood pressure, and it was just for experimental reasons that they used it to look at the acute effects of lowering insulin on testosterone. So it's there because it's an insulin lowering drug, but you wouldn't use it in clinical practice.
Question at the back.
So is it a myth that PCOS affects circulation?
It's a myth. In the sense that it's a good question though, because if you come to IVF and you stimulate lots of follicles, which is what you do, the follicles you get from polycystic eggs will be more. You'll get more eggs, but some of those follicles will contain eggs which are past their cell life. They've matured too early, and therefore they won't fertilize them anymore. If they do fertilize them, so the proportion of eggs which are not very good may be slightly higher. The actual number of healthy eggs that you get in an IVF program from PCO is actually slightly higher without polycystic eggs because there are more follicles. And what's more, the embryo quality is no different. If anything like that. So that's not a concern if you do have to.
Got time probably for 1 or 2 more questions. So we go up. Second table from the back and then the back table.
I just wondered, is there any link with PCOS and ovarian cancer?
Nothing that's firmly established. There's one paper, and not a very good one, which suggests there is a link, another one which suggests there isn't. So no, there's no mechanistic reason why there should be. In fact, indeed, there's more of a link between women who ovulate more frequently and ovarian cancer because of the idea of damage and repair each ovulation cycle. But certainly no firm evidence to use it.
I'm looking for a bit of reassurance. I've recently watched times with our fertility specialist. I have polycystic ovaries and my husband has a really low sperm count. Is cloning a viable option for me in that situation?
Well, it really depends on how low the sperm count is. So if you've been trying for a while and you've had reasonably regular cycles, then there's no point in you having one. If you don't have a cycle at all, then it really depends on the level of the sperm count. And so it might be worth a few courses of clomping up to 6 months to try that out, because unless you've got no sperm, but you can, because there's not a lot to lose except 6 months. But if you can put off having IVF.
Yeah, that was my argument.
Yeah.
All the pressure on me is weight.
Yeah.
And these are other opportunities.
Yeah.
So,
well, in the meantime, it's probably not bad. It's lose a bit of weight, because they've given you a target. But if you've lost a bit of weight, it might be worth just trying. because you never know. Because when there are two factors affecting fertility, a male side and female side, you can't be sure what's more important. Maybe the low sperm count is only a moderate impairment, and it will give you a chance. So if you can get the doctor, let's do a specialist to monitor 6 cycles of chronic. I mean, after a couple of cycles, it doesn't work. It doesn't work. But it's worth a try.
I did suggest it. They shut me down point blank. Said no, it won't work. There's no point.
Well, it's less likely to work. It doesn't mean it won't work.
Thank you.
And last question here.
I was just wondering about PCOS being hereditary. If the ladies and mothers that do manage to have children have daughters, what is the likelihood of them having PCOS?
The likelihood of them having polycystic ovaries is about 50-50, we think. But the likelihood of having the syndrome varies. There are plenty of women with polycystic ovaries out there who have no symptoms. And we did a study, for example, of women in families. So we had sister pairs. We had a patient who, this was for our genetic studies, we had a patient who had the full-blown syndrome, and she could have a sister with polycystic ovaries who had no symptoms at all. So that illustrates that within the same family, you can have polycystic ovaries, which we think is, there is a hereditary factor there. But that's not the whole answer to why you get cycle disturbance. There are other factors which come into play. So you're not condemning the daughter to a lifetime of infertility.
Great. I'd like to thank Professor Franks for his talks. Thank you very much.